I am a doctor working as GH, Singapore General Hospital, for almost more than 25 years. And my journey started as a trainee registrar here. Now I'm a consultant and bring my service to the nephrology as well as to the community. For example, I also do some work regularly in dialysis centers, and I am involved in all sorts of nephrology, all points. But my main interest is in chronic kidney disease, mainly the preventive and early management aspect. That's my introduction. And I am well qualified and accredited according to Singapore Medical Council and also General Medical Council of the UK, as well as my own country. And I think that I will be able to give a little bit of brief but explanatory information about this chronic kidney disease to the community and to also our physicians community, which will include all doctors, not only nephrologists. Just for one information, that this chronic kidney disease mainly is caused by diabetes in 70% cases, and 10% cases is because of hypertension, 20% cases from other diseases like glomerulonephritis and other congenital and hereditary diseases. So major burden of the chronic kidney disease come from the community who are suffering from diabetes, and diabetes consists of more than 11 to 12% of the community population suffers from diabetes. So you can expect such a big load of chronic kidney disease in the community. Okay, thank you very much for inviting me for this very important subject of chronic kidney disease. I must tell you that this chronic kidney disease is not an isolated disease. It has been in the world for long time, and currently, according to statistics, about 10% of the population in general suffers from some sort of chronic kidney disease, which is in the literature, in the statistics, but the people might not know that. That's why this sort of communication is important for people to understand that they are among the group of chronic kidney disease, which has a big impact ultimately. If any one of them becomes in one of these 10 guys of his community or his country, is going to develop end-stage renal disease in course of time, requiring dialysis support or transplantation if available. So that's why this chronic kidney disease is important for the knowledge, for the health education, because this chronic kidney disease actually can be prevented, can be halted from progressing to end-stage renal failure. So that's why I was very much interested and supported this interview, and that's why thanks you. This is a very important question that I might mention, because uh, ultimately we have to treat the chronic kidney disease no matter how it develops and when it develops, and who will treat the chronic kidney disease, because as I mentioned to you, chronic kidney disease according to statistics is 10% of the society, a community, or a country. That means almost 1 in 10 patient, person is suffering from chronic kidney disease. So the management and treatment should come from the basic root level, from general physician, family physician, polyclinic doctors. Cannot be a nephrologist on the first day. You understand, the nephrologist actually see the patient of chronic kidney disease in an advanced stage, when actually many things can be controlled but is limited. The patient has started the journey of chronic kidney disease, and maybe he is in the middle of the journey when he reached the nephrologist, and by that time nephrologist may not be able to push the car backward to the original good state. He can only merely prevent the further progression to the final stage. She can try to slow down the progression. Maybe that can do. So most important management plan comes from the community, from the primary doctors. So this slide, I think I am trying to explain the management of chronic kidney disease from the beginning, what we should concentrate and what we should treat and how we should treat. This is not a complicated slide. This is just an algorithm of the management. As I mentioned to you, when the patient with a diabetes or hypertension or family disease, here we take a diabetes, comes to the physician, And as I mentioned to you earlier, the physician need to do a CKD testing according to the National Health Service of UK guideline, and also approved by KDIGO guideline. He should do urine for albumin test and also renal function test, which invariably all general physicians do that, and that will satisfy his question that whether this patient has CKD or not. So suppose the patient has CKD in terms that the physician found that he has albumin, the patient has albumin expression in the urine, and also his GFR is low, is dropped. That means he's not in the normal range anymore. So here the first line of treatment is not that very much unique to speak here. Suppose you have an infection and you need an antibiotic. Kidney disease is not like that. Kidney doesn't have any specific medicine for the chronic kidney disease. Chronic kidney disease is a conglomerate of a lot of conditions, lifestyles, original diseases, and patients' lifestyle practice, including the food, because anything other than the medicine that goes through people's mouth is the food. So if food is no good for the kidney, no matter how good the medicine is, it will not affect as much as good as expected. So that's why I should mention that the is a holistic management, to speak the truth. Whatever you are treating, whether it's diabetes or hypertension or cholesterol, hyperlipidemia, you treat properly, nicely, according to the guidelines to maintain the normal environment and normal status of the disease, so that the disease itself doesn't progress and doesn't affect the other organ like kidney. Number one, this is the in terms of management as a doctor, we call pharmaceutical management, drug therapy. The next is the lifestyle. Any management involves a lifestyle. As I told you that the other than the medicine that goes to the mouth is the food. So if the patient is taking very good medicine for diabetes, taking insulin and tablets, and also taking blood pressure medicines and also cholesterol pill, the brilliant doctor is giving him, and the patient is very compliant with the medicine. But if his lifestyle is not that good enough, the medicine will not help. Medicine needs help. Anyone needs help. I need help from my nurses, from my colleagues, and as for example, I am getting help from you in disseminating my information or my knowledge to other people. So what I think that first thing first, the therapeutic purpose has to be optimized, have to be excellent. Next is the food, and next is lifestyle. So first thing first, when the patient comes with diabetes and or suppose hypertension, he has to do CKD test to find out whether there is a CKD or not. So this part of the slide, this called is screening. So this is called CKD screening for the people who can develop CKD. There is a score system, and it is Q kidney risk calculator. Just click it and put the parameters like age, weight, diabetes, etc. It will give you the chance of having chronic kidney disease and chance of having end stage kidney disease in that particular patient's life. So he will know that what risk he has for CKD development in later. Then, as I mentioned earlier, the check urine routine test and protein creatinine ratio, that is albumin creatinine ratio. Do the blood test for the glucose, creatinine, check your blood pressure, do ultrasound of the kidney, because ultrasound is important in the sense that it will give you a structure of the kidney. That is nice to know. And first, one test is not enough. You need to repeat this test. As long as the tests are normal, you need to repeat it every 2 to 3 years according to the advice of the doctors. So this is the first thing first. Suppose the patient doesn't have hematuria and proteinuria as here, so no CKD, because GFR is good. So no CKD or pre-CKD or CKD0, whatever you say, with that common conditions. This patient can be monitored by clinician nurses in the poly or anyone every 6 months to make sure that the conditions are stable. And for particularly in diabetes situation, now new medicine SGL2 inhibitors, I think all the doctors and is very well. It's like a panacea. They say that it gives a good control of the diabetes, it protects the kidney, it protects the heart, etc., etc. Okay, go ahead, as long as indicated. And also there are some other medicines like ACE inhibitors, ARB, that means angiotensin converting enzyme inhibitor, angiotensinogen type 2 receptor blocker for hypertension, high blood pressure, and diabetes cases. The guidelines says that you can use this medicine preemptively in case of hypertension and also in case of diabetes mellitus if the patient has a protein leakage. These medicines are renoprotective and cardioprotective. So even when the patient doesn't have kidney disease but have the pre-CKD conditions like diabetes, as you asked earlier, this strategy as a first line of therapy need to be taken. That means excellent management of diabetes, hypertension, etc., etc., checking the urine protein and urine renal function, and maintaining good control of those things, plus preferably giving SGLT2 inhibitors for diabetes control and for hypertension, and if the patient has mild proteinuria, to use these ACE inhibitors or ARB. This is the first line of therapy. Now next slide will show you that suppose the patient has developed hematuria or proteinuria and the creatinine started to increase. That means the GFR started to drop. So that means he has developed an early CKD stage, then CKD stage 1 and 2. That means GFR is more than 60 yet, not less than 60. So this CKD stage 1 and CKD stage 2, but the patient has protein leakage, so he has CKD now. So when he has developed chronic kidney disease and the patient is basically a diabetes patient, so you know that the physician have to do something more than control of the diabetes and high blood pressure. So what are the things? So here the nephrologist management plan, as you asked, will be to try to halt the CKD advances. And how they can do that? They can do by good control of high blood pressure, to try to keep the blood pressure according to the guideline less than 140/90 if the patient has no protein leakage. But if the patient has protein leakage in the urine, the pressure control should be a bit more stringent, 130/80 try. Then control the diabetes, keeping the HbA1c less than 7. Then if the patient has suffers from nephritis, glomerulonephritis, have to good control of it, good medicine. And also the protein leakage of the urine need to be treated by antiproteinuric medicine, which is mainly, as I mentioned earlier, ACE inhibitors, ARB, and also sometimes we use mineralocorticoid receptor antagonists, which is a spironolactone in short. And there is another medicines also coming up, non-steroidal. I think FDA has approved already, and SGH was involved in this we call Finredon, non-steroidal MRA, and I was a principal investigator of that in SGH. So that's completed, and we heard that FDA has already approved for diabetic patients with proteinuria usage. It has less hyperkalemia tendency, and now they have progressed to non-diabetic patients use. There's another program is going on. However, we were happy to be involved in that non-steroidal MRA, and just I was the principal investigator of that and it's completed. So then the other lifestyle, which includes a body mass index, should be maintained less than 25% by food habit, by cholesterol control and diet habit, etc., and avoiding calorie-rich food. And the control of water load. Frequently this patient can develop edema because of the proteinuria. They can develop a nephrotic state, swelling of the water, leg and face, etc. This has to be controlled by furosemide to reduce the congested state of the body, to reduce the congestion of the heart, that means to reduce the preload in order to prevent the heart problem. And also they have to check for the coronary artery disease, etc., etc., so that they can take preemptive management. And the lifestyle, and means that he should maintain a healthy lifestyle so that the person doesn't get repeated infection of the urine, chest, etc., etc., because each infection damages the kidney. So this is the next step which the physician will take, and he will educate the patient to maintain. Next point, I think I can stop here in answering your question. This the first management and the planning. And I think you can progress to the next question, which I think you have one. This is question is very relevant in terms that CKD patients, the patient can have other problems also, and uh, a patient have frequent problem of the muscle pain, joint pain, back pain, neck pain. They have because some patient can have gout, which is quite common. They can have gouty arthritis, and many most of the CKD patients are in the elderly age group. They can have osteoarthritis and other aches and pains across the body. So, and you know that these aches and pains, patients usually doesn't go to the doctors. They just buy over-the-counter NSAID like aspirin or like Voltaren or Indosit. And sometimes, most frequently, they use plaster, ketoprofen plaster, Festum gel, etc., etc. So these they don't ask doctors because they are feeling pain, and the colleagues, the friends, they use that, so they just use it. They have at the home, they use it. And in our practice we have seen that it is actually quite common. In a day, when I see about say 10 to 20 patients, almost 5 patients will have these things. They are using either ketoprofen plaster or Festum gel, or they are taking on and off one tablet or two tablets of the NSAID. I'm not mentioning about aspirin as I said, because aspirin they take usually for ischemic heart disease or cerebrovascular disease, and the dosage is 175 to 100 milligram, and that dosage is not considered as an NSAID. It is actually antiplatelet agent in this dosage. So I am not mentioning about the aspirin below the dosage of 100 milligram as I said. I am mentioning about aspirin as a 300 milligram tablet, or Indosit, which is quite common, Voltaren, which is quite common, and also the Festum gel and ketoprofen plaster, which is very common. And I will say every third patient or every fourth patient is using one of that or not, the patient of CKD which comes to us. And also they get it from polyclinic, from general physicians, and they don't tell the doctors that they are suffering from chronic kidney disease, or the doctor doesn't know. So this is the way they use it. And actually the part of the question was that NSAID is used in CKD is not to be confused as NSAID is used for the treatment of CKD. That is not the inference or understanding. NSAID they use frequently in CKD patients because of other issues and without knowing the impact. And the nephrologists also, they don't say frequently that I'm using the plaster or the tablet on and off pain in the neck or shoulder or something like that. But when they tell the nephrologist, and the nephrologist has a duty to tell them that NSAID is not good for the kidney CKD patients. I mean, not good for the CKD patients. For normal kidney is okay. For normal kidney has enormous power to counteract any abnormalities. But a diseased kidney, a compromised kidney, doesn't have that power to counteract the bad effect of bad medicine. So what NSAID does is basically is a prostaglandin inhibitor. It inhibits a particular enzyme known as cyclooxygenase enzyme, which is responsible for the synthesis of prostaglandin. Prostaglandin are actually hormone-like substance which is in the tissue level, and there are several types of prostaglandin. Some prostaglandin are vasodilator, increases the perfusion of the organ, and some prostaglandins are vasoconstrictor, which try to maintain the integrity of the blood supply of the organ, particular organ. And also they have other actions of also on the kidney, like sodium transport, glucose metabolism, etc., etc. But in short, in the kidney, the prostaglandin is responsible for maintenance of the blood flow in the glomerulus and the tubules, renal tubules, because the kidney is an organ, a small organ, about two kidneys maybe combined together, maybe about say 1 kg or less than that, but it has an enormous blood supply. In a minute, it receives 1,200 ml of blood from the circulation. so much blood dependent because it's understandable because it filters the blood. So the more blood it can receive, the more filter it can make to clean the blood. So this blood flow depends on the vasodilator prostaglandin inside the renal tissue, which are locally synthesized. It doesn't come from the other places to the kidney. The kidney synthesizes its own prostaglandin from its sterol substances with the help of the enzyme cyclooxygenase. And this NSAID inhibits the cyclooxygenase enzyme. And as the cyclooxygenase, there are two varieties, 1 and 2. 2 is locally produced in terms of need. The 1 is systemically available. So these enzymes, cyclooxygenase in short is called COX 1, 2, are inhibited. So as a result, the local prostaglandin is not manufactured inside the kidney. So when these vasodilator prostaglandin are not manufactured, there are other substances like endothelin, etc., inside the kidney which are vasoconstrictor. That means they constrict the blood supply, blood vessels. So when the blood supply or the dilator is down, the constrict becomes upregulated, up. So there is more vasoconstriction in the kidney. So the blood supply in the kidneys filter that we call glomerulus, and the kidneys tubules, where the modification is formed, we call renal tubule, are compromised. They suffer from ischemia. So GFR, glomerular filtration rate, which is blood flow dependent, comes down, worsening the CKD, and also tubular blood flow drops, disrupting the tubular function, which is sodium excretion and also excretory services, all the poisons, and also water excretion. As a result, the glomerular and tubular function get depressed because of the absence of dilator prostaglandin, because of the inhibition caused by the NSAID. That's why whenever the patient takes NSAID, their GFR goes down. And then we ask why your GFR went down. Your GFR was quite stable for the last few months. They said that, oh, I took 1 tablet of Voltaren because I had a pain in the neck. Sometimes they said I am using Cotrotop Plus in the bag because of the chronic backache that I am having. So in that case, then we assure them, we tell them that cannot use. This is absolutely contraindicated. It will worsen your kidney function incurably, and you will end up with NSAID dialysis earlier than anticipated. We give them alternative like paracetamol with vasopressin, then non-opioid analgesic like tramadol, etc. Sometimes we do uric acid levels. Many times they can have gout, hyperuricemia, which is not acute, so they don't understand. At that time we use anti-uricemic medicine like allopurinol and other things. So there are alternative as well. NSAID is just no to NSAID, whether tablet or local topical, because topical is absorbed through the skin and reaches the kidney to the same thing. So this is your answer to my answer to your question. In this slide, I have written in the lower part of the slide that the pain gel, the Fastam gel, plaster, Ketotrop plaster, NSAIDs, and unknown traditional medicines also, because many of the traditional medicine may have NSAID inside to get a pain relieving effect. So this is absolutely contraindicated.
Right, doctor. So, doctor, what are your recommendations for the various lifestyle changes that one can adopt for the betterment of the health of CKD patients?
Okay, so this is I was telling you from the beginning, after telling you the plan of management, which I mentioned in the previous slide. So this is known as non-pharmacological management of the chronic kidney disease. Like every disease should have a non-pharmacological management. So this non-pharmacological management mainly consists of two things. One is lifestyle, another is food style. Because as I mentioned to you, the other thing that goes through the mouth of a patient other than medicine is the food. So food has to be good at the end of the day. So there are several foods have good substances and bad substances. Food is food for our nutrition, but don't think that all food are innocent. They don't have any poisonous substances. So for example, the vegetables and fruits has a lot of potassium, and potassium is very important for health. It makes us healthy. It gives muscle power. Muscle movements is responsible by is caused by the potassium, an important substance. Normal kidney can maintain a normal level of the potassium no matter how potassium rich food you are eating. But when the kidney function become compromised, and if a person takes a potassium rich food, the potassium level goes up beyond its limit of 3.5 to 5 we take. And when the potassium level goes above 5, actually it can cause heart irregularity, we call it a fibrillation, and it can also cause cardiac standstill. That means heart can stop. The patient can heart can stop and they can collapse anytime. So that is about the potassium. There's another thing we call phosphate. The many food contain phosphate, like your beans and nuts and all seeds, and also the bones and the meats. The phosphate is very important because your bone is hard because of the calcium and phosphate. So we eat calcium and phosphate the food, and that is metabolized and deposited in the bone. The bone becomes strong. Teeth become strong. Normal kidney can handle this calcium and phosphate no matter how large amount of phosphate containing food, as I mentioned earlier, you are taking. But chronic kidney disease, kidney is compromised. So if somebody takes a lot of phosphate containing food like your seeds and nuts and beans and meats and seafoods, etc., the phosphate levels goes up. So when the phosphate levels exceeds normal level, that is bad for the bone metabolism, and we call it renal bone disease. And also that is bad for the calcification. I mean, the blood vessels and the soft tissues get calcium and phosphate deposited like the bone, so they lost their integrity of function. That is phosphate. Another thing is your sodium. Sodium is we get from the food. We also have to use sodium in our cooking, and we have to take salt, otherwise you cannot eat. And also sodium is important for absorption of the glucose in the gut. Normal kidney can balance a little more sodium that a person take, but diseased kidney cannot. So if the patient with CKD takes a little more salty food like crackers, cheeses, biscuits, etc., salty foods, and seafoods, etc., the sodium level goes up. It causes hypertension. The blood pressure also goes up along the sodium. There's a more water retention in the body, we call congestion, which damages the kidney plus the heart. This is very important for the CKD management. That's why all the CKD patients that we receive, our nephrologists, we refer to the renal dietitian. The dietitian advised them how to take the requisite amount of sodium, potassium, and phosphate, and the protein in the food. And accordingly, the patient practices the food style. The other important thing, the food is not guideline yet, but a lot of opinion has been appearing in the literature, is oxalate. Oxalate is a very common constituent of our food. For example, your green vegetables, your seeds and nuts, and the meats are very high in oxalate. And we eat meat that converted to amino acid, and amino acid is metabolized in the liver, and the final product of amino acid metabolism is oxalate. And you know that, and everyone knows that oxalate stone is a very common stone of the kidney. In renal stone, calcium oxalate stone is the most commonest. There is a stone formation, but in microscopic level, when the blood stream have a lot of oxalate that reaches the kidney, and the kidney has a lot of oxalate in solution, and this oxalate deposits in the kidney tissues, causing crystalline nephropathy, not producing the stone. The stone is just a solid structure stone in the bladder, but before the stone formation, this oxalate in a molecular level is precipitate in the renal tissues, damaging the kidney. We call oxalate nephropathy. So this further damages the CKD. So if the patient is not aware of the high oxalate containing foods and doesn't limit this food according to the dietitian advice, kidney progresses. That's why sometimes we see the CKD is progressing separately, increasing, exceeding the predicted progression. This is because of this food style, food habit, lifestyle, etc. That's why the lifestyle modification we advise our CKD patient, we call that is retardation of CKD progression. So here you can see that in this slide, I have written that you need to minimize fruits and vegetables that are not so good for the kidney disease as advised by the dietitian. Sometimes mushroom is not so good because it contains a lot of oxalate, meat also a lot of oxalate and the phosphate, etc., etc. And the other things that some people takes a health supplement from traditional shops, and many health supplements has ingredients which are actually not that helpful for the kidney, and the kidney get damaged. So this is in short about the lifestyle in consuming food and traditional medicine. And the other lifestyle is that too much exercise, too much running, too much jogging. This makes the patient dehydrated and also releases a lot of muscle enzymes which can damage the kidney. So we also tell them that moderate your daily exercise and daily lifestyle habit. So the other thing, the patient's lifestyle, we usually advise a patient uh, is, uh, is a situation where the patient can have an acute insult or acute injury to the kidney. Suppose the patient is having an infection, pneumonia or urine infection, the kidney will be damaged because of this sepsis process. Or the patient has some food intolerance, he went to some food stall, when something not tolerated start to have vomiting and diarrhea, that will make him dehydrated and will affect the kidney, will cause acute kidney injury. Suppose his blood pressure is not well controlled, he is not that much careful about his medicine because of his lifestyle habit, so it can fluctuate too high or too low, both can affect the kidney. So in this way the kidney can be secondarily and yeah, unknowingly be affected when already he is having chronic kidney disease. That's why in the lifestyle modification we advise the patient to be careful of those situations where the kidney can be affected. These are not related to your medicine, but indirectly can affect the kidney. And once the kidney is damaged by an acute injury, it doesn't come back to the previous level. It goes into the further next stage, culminating to earlier stage renal failure. So in this way, they have to control their lifestyle in terms of food, salt, water intake, lifestyle uh, uh, modification, and the other things that in their lifestyle they have to meticulously follow the doctor's advice in terms of medical, I mean, medicine consumption, which is called non-compliance. In the lifestyle, they have to be very much compliant to the medicine and follow up with the doctors. So if there is non-compliance, as I explained to you this side, then the doctors might not help properly, and the chronic kidney disease may progress a bit faster. So this is in short how he can modify his lifestyle in terms of food habit, lifestyle habit, and the compliance to the medications and the follow-up. I think I could explain to your question. This is a very important question, and this is a very confusing question also. That means who will take care of this CKD patient
Yes.
and
Yes.
from what stage? Actually, according to the guideline, this has been well explained.
Hmm.
In this slide, as I mentioned to you earlier, in the CKD 0, as I mentioned, CKD 0 stage or CKD 1 stage. CKD 0 is the primary physician. When the primary physician do the CKD testing according to this one,
Yeah.
do the urine test and the renal function test, they find the kidney problem, then it becomes CKD stage 1, 2, etc., etc.
Yeah.
That doesn't mean that the primary physician will just send the patient to the nephrologist, because then the load will be high. I explained to you that CKD is a very high load.
Yeah.
10% of the population, for example, in Singapore population is 5 million, is 500,000 CKD. So can you imagine the
Yeah.
nephrologists of Singapore can manage this 500,000 patient?
Oh.
Cannot. So the primary focus is the primary care physician, the polyclinic doctors, general physician, and the family physician. They have to take the lead in the management of the CKD. As you explained very nicely, that identify the comorbidity and the cause. So the cause we have already explained: diabetes, hypertension, etc., 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 etc. In this way, you see here all the causes are here, including the family history. That means the person's brother is a dialysis patient, he doesn't have any kidney, but he is supposed to have kidney problem as a CKD 0. So these are all in the primary health care. So comorbidities, all blood pressure, cholesterol, and other comorbidities, joint disease, arthritis, etc., etc. These are all, in particular, the scope of the mention of the general physician, primary physician. So he will take care of all this system according to his knowledge, his facility, and his availability, as given by the government or the system. So now, what I will say that when to send to the nephrologist. The next slide explain. This is a KDIGO slide. This slide, this portion is a KDIGO portion, which shows at what stage of CKD and at what stage of albuminuria profile you need to do what. I am showing you this slide. Suggested monitoring of CKD in general practice. This is the headline. This is the title of the slide, and this is given by the KDIGO, Kidney Disease Improving Global Outcome, based in America, but it's a conglomerate of all the kidney societies of the world. So you see the stage. G1 is G stand for glomerular GFR. So like CKD stage and other things. Just one moment. It's okay. So this G1, G2, G3A, G3B, G4 is CKD stage 1, 2, 3A, 3B, 4, and 4, 5. And albumin, the next line is the albumin category: microalbuminuria, normal albuminuria, microalbuminuria, macroalbuminuria. So how you will manage when to send to the nephrologist? You see, the next step is treatment. This treatment is for the general physician, polyclinic physician, family physician, non-nephrologist who are encountering the patient. I mean, he can be an endocrine physician, he can be cardiovascular physician, he can be a neurologist, but not nephrologist. If he's nephrologist, is okay. Nephrologists know what to do. So in this case, the treatment for the particular physician who we think that is non-nephrologist, same thing. It's comorbidity. Treat the blood pressure according to the guideline control. Give ACE inhibitors, ARB, if there is albuminuria. Microalbuminuria and macroalbuminuria. And if there is a macroalbuminuria but no blood pressure, normal blood pressure, still you need to give ACE inhibitors and ARB as a renal protective medicine, kidney protection medicine. Then you should consider statin, which has a lot of beneficial effect, as explained to you. And also, if the patient has hyperlipidemia, you have to give. And the aspirin, the mentioned to 75 milligram for secondary prevention, because most of these patients can have a vascular disease. And then next is advise lifestyle changes as appropriate, which I explained earlier. So this portion is not nephrology particular, is the primary physician, family physician, polyclinic physician, or any physician who is dealing with that particular patient, maybe a cardiologist, neurologist, or endocrinologist, or orthopedic, or maybe an autoimmune rheumatologist. So when to send the patient to the nephrologist? You see the referral. The next row is the referral. This is from KDIGO. I am just telling you. Referral happens, you see, in CKD stage 4 and CKD stage 5. You can see that up to CKD stage 3, general physician, as I explained to you, can manage the CKD from the planning and diet, drugs, and the lifestyle is explained in the. This is international slide. This is not my slide. This is worldwide accepted slide produced by the KDIGO, and the referral comes at the CKD stage 4, because otherwise nephrologists will be overwhelmed. So many CKD patients overwhelmed, and nephrologists cannot be overwhelmed. If they are overwhelmed, then CKD management will become abnormal. So you see that referral is made in CKD stage 4, which is GFR when drops to, I'll say, less than 30. Less than 30 is CKD 4. So at that time, the nephrologist will continue the same medicine, will optimize the further thing about the medicine, the lifestyle, the food, and then you see the nephrologist will discuss with the future plan, advanced planning with the patient. If your GFR further decreases, if you advance to end-stage failure, what you will do? You will do hemodialysis or peritoneal dialysis, or you will do transplantation. Of course, at the same time, maximum management and lifestyle modification will continue, and also preventive medicine. Some medicine actually do have like a pyridoxine tablet, vitamin B6. Vitamin B6 inhibits oxalate production. It helps in terms of renal recovery. Sometimes we use allopurinol as an antioxidant, especially when the patient is hyperuricemia. We use mineralocorticoid receptor antagonists like phenytoin and other things. They all have renoprotective effect. This is the drug therapy, but it doesn't mean that the patient will not progress to other stage. So nephrologist referral start when the patient is at point of no return. That means CKD stage 3 ended, and there is point of no return. So this is the point of no return. You see, I have written this slide. CKD stage 3B is a point of no return. So at this stage, the nephrologist take over the patient through referral, and up to that, the general physician or whoever can continue the management of the patient in that way that we have discussed earlier. So as you mentioned here, when the nephrologist will take over, the nephrologist will take over in a later stage, but it doesn't mean that if the nephrologist encounters the patient in earlier stage, he will not take over, he'll take. But most of the time, this CKD patient comes to us at a stage of CKD 3. But it also depends on the particular country, also country dependent. For example, in Singapore, the referral from the polyclinic to the nephrologist is made at EGFR 45 mL. So it's a CKD stage 3B. 3B start from 45 to 30 is a 3B. So it depends on the country, but in general, KDIGO advise that in general, nephrologists need to be referred by CKD stage 4 at the beginning, and in Singapore, our polyclinic refers to us as CKD as a GFR 45, which is CKD 3B. But because our polyclinic doctors are all general physicians, are also well aware of the CKD management. So I think I have explained to you this particular question, which refers to the particular management of the nephrologist and when to refer and when they take over, and what the role of the primary physicians in respect of CKD. I'd be a nurse